Good evening and welcome to Doctors on Call. I'm Dr. Dustin Lucarelli, a surgeon with the Fairview Mesaba Clinic in Hibbing, and I am your host for our program tonight on lower GI problems. I'm happy to welcome our panelists for this evening. They are Dr. Daniel McKee, a gastroenterologist with Northland Gastroenterology, and Dr. Ayan Rage, a gastroenterologist with Essentia Health. Our medical students answering phones tonight are Kate Anderholm of Nisswa, Minnesota, Amy Larson of Wilmer, and Leah Larson of Bemidji, Minnesota. The success of this program is very dependent on you, the viewer, so please call in your questions on constipation, colitis, diverticulitis, and colon cancer, and we'll do our best to address them. The telephone numbers for your questions can be found at the bottom of your screen. And now on to tonight's program. So why don't we just start off with a little introduction and special clinical interest you might have. Why don't we start with Dr. Rage?
Yes, my interests include inflammatory bowel disease in particular, and also colon cancer screening. I do take care of all GI-related disorders, but if I say particular interest would be inflammatory bowel disease, specifically Crohn's, ulcerative colitis. Also take care of patients with liver disease, what we call cirrhosis and stage liver disease.
Okay. And Dr. McKee, is there any clinical interest that you may have?
Yeah, my interests are very similar to Dr. Rage's. I'm interested in inflammatory bowel disease, cancer screening, and I have a particular interest in liver disease as well.
Okay. So I have one question for either of you. When we talk about colon cancer and colon cancer screening, can you give our viewers just kind of the general recommendations as to how colon cancer screening is developed and why we have it? We start with Dr. McKee.
Well, how it's developed, I'm not sure how to answer that. Colon cancer screening has progressed and to the point where there are a little bit different ways of screening for colon cancer today than there were even 10, 15 years ago. But I think maybe the key points are that colon cancer is the cancer that we can most influence by screening techniques, much more so than other cancers such as breast cancer, prostate cancer. In terms of screening techniques, colonoscopy is still the gold standard. There are stool tests that are less invasive, they're less accurate, but they're less expensive. And there is a test that can be done with a CT scanner, which is relatively accurate as well and certainly has a role. Those are, I would say, are the three main techniques.
Okay.
Yeah, just wanted to add, just like Dr. McKee said, that certainly colon cancer is one of those preventable cancers, and through a colonoscopy you'll be able to detect and also prevent with the removals of polyp. If you have average risk of colon cancer, meaning you have no family history of colon cancer, you don't have colitis, then screening is recommended at age 50. And for people with family histories earlier than that, approximately 40 years or even younger, depending on what your family history is.
Okay. So Dr. McKee, we have a question here from Pristine from Duluth. She asked, does C. diff damage the colon?
C. difficile is a bacterium, and a significant number of individuals harbor it without having symptoms. When it becomes an issue is when that bacterium grows up in larger numbers and sort of overwhelms the colon and can cause colitis or inflammation of the colon. That's likely to occur when a person takes certain antibiotics, which can preferentially kill off the so-called good bacteria and then leave the C. difficile bacteria kind of uninhibited by the good bacteria and then result in colitis. And in that case, in that situation, it certainly does damage the colon, and it can be anywhere from a relatively mild infection, which can be treated outpatient, to life-threatening infection requiring admission to an intensive care unit, and in extreme situations could even require surgery with removal of the colon.
And Dr. Rage, a follow-up to that question is, once you've had C. difficile colitis, is it more common to get it once again?
Certainly, yes. There's a risk for a recurrence, and you really want to make sure that you do take the antibiotics that are prescribed and complete the course. And if you're still having symptoms, it's important to go back to your doctor, in that you may require a longer term. Some patients have difficulty in getting rid of the initial C. diff infection, and those do require, like I said, a longer treatment course. It's really important that you go through a very rigorous, almost like a disinfection. Make sure you clean all your surfaces. You want to bleach your sheets. So really, it's a very hardy bacteria. So simple cleaning techniques don't get rid of it. So that's how we can minimize the risk of getting it again, is making sure that you do a really good job of disinfecting all surface areas.
Okay. And Dr. McKee, Anne from Duluth asks, fecal transplants and their effectiveness.
Fecal transplant is a newer technique for treating C. difficile, and it's actually, it may sound kind of disgusting, but it is very effective. It works almost all the time. There are different ways of administering. It can be done through a tube advanced down the nose and into the lower part of the digestive system, or done as an enema, or administered through a colonoscope. But it is very effective in treating C. difficile. It almost always works.
And just to add to that, the fecal transplant usually is reserved for patients who have a difficult course of C. diff that don't respond to the typical antibiotics. So it's not something that we go as a first line. It's more of a, after the usual conservative therapy have failed. But like Dr. McKee said, it is quite successful, and it is something that we do offer at Essentia Health.
Okay. And Dr. Rage, here's a question from Duluth. What are the risks of a colonoscopy if you have an anal fissure?
Well, anal fissure is basically a little tear on the outside of your rectum, or actually in the anus. So it's not really in your colon. So a colonoscopy would not basically interfere with the anal fissure. During the colonoscopy, I would take a look and making sure that the fissure, basically where it's located, how deep it is, if it's healing. The colonoscopy in and itself does not make the fissure any worse.
Okay. And Dr. McKee, I have a question here from Murdy. They ask, at what age can you stop colonoscopies?
Yeah, that's a good question. The answer is it has to be individualized. The guidelines are that you screen most people unless they really are not in good health up to 75. The next decade, 75 to 85, you definitely would individualize. So if a person's at higher risk, if they've had precancerous polyps, if they have a strong family history, you might well go into that next decade. Rarely would you screen anyone after 85. So somewhere between 75 and 85 for most people if they're in reasonably good health.
Okay.
And just to add to that, in that age group, 75 to 85, your risk of polyp formation is high. So just like Dr. McKee said, if you're relatively, if you're healthy and you can tolerate the prep, it's very reasonable to undergo a colonoscopy. It's safe and it's very effective in removing polyps and detecting polyps.
Okay. And Dr. Rage, here's a question from Duluth. What are some of the latest treatments and removal for hemorrhoids?
Okay. Well, there's kind of take it back step. There's several types of hemorrhoids. You have the external ones and the internal ones. Usually the external ones, we leave it to the surgeons, and that does require, being under anesthetic, and because those hemorrhoids you could feel them. They're highly innervated. Internal hemorrhoids are usually not felt by the patient. So unless they're large or symptomatic, we usually treat by preventing constipation or what led to the development of the hemorrhoid to begin with. If they are bleeding and they're large, sometimes we do band them. We put little rubber bands, almost like a rubber hair bands, and basically that would strangulate the hemorrhoid and slowly have it slough off. But the prevention is treating and preventing constipation to stop the hemorrhoids from getting worse.
Okay. And now, another question that I have for you, your Dr. McKee, is there a good test for H. pylori, and where do you get it?
Well, maybe we'll start with where do you get it. Most people acquire H. pylori when they're quite young, usually in childhood, and they're asymptomatic, so they're unaware that they have it. And most people who have H. pylori, which of course is the bacteria in the stomach that predisposes to ulcers and even increases one's risk for gastric cancer, most people will go their whole life and never have problems from it, never be aware that they have it. It's thought to be transmitted via fecal-oral contamination, so spread from person to person, basically by poor hygiene types of things. In terms of a test for it, there are a number of different tests. There's a stool test that's really quite accurate. There's a breath test for it that's also accurate. If you're having an upper endoscopy, a test with a lighted instrument down the throat and looking at the upper digestive tract, biopsies can be done which will reveal H. pylori. You can also do a quick test called a CLO test, where you take a tissue sample, put it in a little chemical agar well, and if the H. pylori is present, it will turn the agar well color and give you a quick answer as to whether or not it's present. So there are a number of different tests that can be done. The clinical situation might dictate which is the most effective, most efficient one to obtain.
Okay.
And the thing to remember about H. pylori is it is easily treatable with several antibiotics. I think it's also important after you do finish your treatment that you are tested to make sure that the H. pylori has been treated. Because if you don't respond to the first course of antibiotics, you may need subsequent treatment. And certain strains of H. pylori are associated with stomach cancer. So it's really important that if it is identified, that it is treated, and that a follow-up is done to make sure that the treatment has been successful.
Okay. Here's a question for you, Dr. Rage. From Virginia, what is irritable bowel syndrome?
That's an excellent question. Irritable bowel syndrome is what we describe as a functional disorder, meaning that there's not an organic cause that's been identified. There's a huge area of research going with inflammatory bowel disease, irritable bowel syndrome, and this just should not be confused with inflammatory bowel disease. Some of the symptoms that people can have with the irritable bowel syndrome is abdominal pain, diarrhea, and there actually is a criteria that one has to meet. And it's a chronic, intermittent abdominal pain with changing in bowel habits, and the pain or discomfort improves with following a bowel movement. So it's more of a diagnosis of exclusion, meaning that you don't have Crohn's disease, you don't have ulcerative colitis, and or celiac disease. All those disorders would have to be excluded. And the treatment for it would depend on whether the patient is predominantly complaining of diarrhea or whether their predominant symptom is constipation.
Okay. Dr. McKee, Kathy from Duluth here asks, does diet have anything to do with colitis?
Well, I think it depends a little bit on what type of colitis she's talking about. So it's a little hard to answer that question. Colitis means inflammation of the colon, and there are infectious causes of colitis. There's inflammatory bowel disease, which is, the common types are Crohn's colitis and ulcerative colitis, and then there are milder types of chronic colitis, microscopic colitis, which has a couple different varieties. And the short answer to that question, trying to lump all of this together, is not much. Again, it's hard to answer with all the different kinds of colitis without getting too long-winded about this, but I guess what I would say is this, to keep it simple. Most digestion, not all, but the vast majority of digestion occurs before food reaches the colon. So whatever you've eaten, by the time it reaches the colon, it isn't what it started out as, and so it's not likely to have a big effect on colitis per se. So I would say minimal effect in most instances without getting into too much esoterica there.
Okay. Dr. Rage, here's a question from Johnson. Do probiotics do anything for colonic health?
So probiotics are basically bacteria, and we do have lots of bacteria that are already in our colon. And for you to have a healthy colon, you want to have a variety of different type of bacteria. So there have been some studies to show that probiotics can help in that case, but really the studies have shown it's particularly in patients who've had a viral infection or bacterial infection, and they take antibiotics, some of their usual normal gut flora has been damaged, and taking probiotics can be helpful in that situation. Or sometimes following a C. diff infection, probiotics can be helpful. But a lot of the probiotics that are available commercially are not active. So whether you're really getting an active treatment the jury is still out there. Some patients say they feel wonderful with probiotics, and in that situation, I tell them continue. But if they're not noticing any difference, I would say to stop taking it.
Yeah, I would agree with that. I think most of the probiotics that you can get at the drugstore are little more than a placebo, simply because the amount of bacteria present is so low compared to what you already have within you. It really can't influence the overall makeup of your gut flora. However, there have been some studies with certain prescription strength probiotics that really do show benefit in certain clinical situations, such as treating inflammatory bowel disease and, as mentioned, in treating C. difficile. So there are certain circumstances, but the idea, you see this advertised on TV all the time, that you should take a probiotic for so-called colon health. The idea that just taking a probiotic for no reason is somehow beneficial is pretty much nonsense.
Okay. And Dr. McKee, here's a question from Wayne in Saginaw, kind of staying on the colitis topic. Microscopic colitis, what are its causes, treatment, and prognosis?
Microscopic colitis is a milder type of colitis than inflammatory bowel disease, which is Crohn's or ulcerative colitis. The typical symptom is diarrhea without pain or bleeding or other symptoms. There are two types, collagenous and lymphocytic colitis. They're treated pretty much the same way. The prognosis is good in that serious consequences from microscopic colitis do not occur, unlike, again, like Crohn's or ulcerative colitis, where there may be complications requiring surgery. Surgery is never necessary with microscopic colitis. Basically, you have diarrhea if it's active and nothing else. So from that standpoint, it isn't particularly serious. It's more of a nuisance. It can be treated effectively, usually with a drug called budesonide. Diet is helpful too. Avoiding certain types of foods is oftentimes beneficial with microscopic colitis. So that's this is one of those exceptions that I didn't want to get into before, but now it is kind of relevant for microscopic colitis. But it has a great prognosis, and really no one, I believe, has probably died a day earlier because they had microscopic colitis.
And just to add, even though we don't know exactly what the cause is, it's been associated with tobacco use. So if you do smoke, you want to quit, as that can increase the risk of relapsing of the diarrhea symptoms. Also, using ibuprofen, Aleve, has been associated with especially lymphocytic colitis. If you do have these conditions, the microscopic colitis, there's an increased prevalence of celiac disease, so maybe getting tested for that certainly be a good idea, talking to your doctor about it.
Yeah, and in addition to drugs like Aleve, the non-steroidals, proton pump inhibitors are associated with microscopic colitis, so drugs like omeprazole, Prilosec, Prevacid, and some of the antidepressants, the so-called SSRIs, have been associated too. So if you've started a medicine in one of those three classes and had onset of colitis soon thereafter, it might be worth exploring switching.
Okay. And Dr. Rage, a question here from Alvin in Duluth. Are there any medications where colonoscopies are contraindicated?
There's no particular medications, no, but what we focus on is the blood thinners, because when we're doing a colonoscopy, we're anticipating that we're going to find a polyp and remove a polyp, what we call a polypectomy. So if you're on a blood thinner for atrial fibrillation, or if you've had a blood clot, it's important that you let us know, and we'll plan accordingly if we can safely stop your blood thinning medication so that we can perform the colonoscopy safely and perform the polypectomy safely.
Okay. And Dr. McKee, here's a question from Don in Duluth. For patients with permanent ostomy and they have chronic constipation, what causes their constipation, infrequent bowel movements with their permanent ostomy?
Well, if they've got an ostomy, an ileostomy or colostomy, there's no reason for that per se to cause constipation unless potentially a stricture, a narrowing is developed from the surgery. So, one thing to consider would be the possibility of partial obstruction as a complication, but assuming that there isn't partial blockage as a consequence of the surgery, then having an ostomy does not cause constipation.
Mm-hmm. And I think from my practice, where I see it with surgical patients with ostomies, they may often come in having constipation and find out they have peristomal hernias. And it's these hernias which can then cause the constipation and such. And in those instances, it may require reoperation or such. So a question for you, Dr. Rage. This is a question that I've often seen with patients. Johnson here asks, is it important to drink all the colonoscopy prep?
That's an excellent question. Yes, and the reason why we say that is we want you to have the best prep, because that will really yield the polyp detection rate. Because if the colon is clean, then we'll be able to see even few millimeter size polyps. So for the vast majority of patients, completing the entire prep is definitely indicated.
Okay. And here's a question, Dr. McKee, from Betsy here in Duluth. So, father and brother, colon cancer, and the patient may have a history of C. diff. Is there any increased risk for colon cancer because of that?
Well, there's an increased risk of colon cancer because she has two immediate family members who've had colon cancer, but not because of the C. diff. So with two immediate family members, it would be helpful to know the ages of those family members when they were diagnosed with their colon cancer, because that would influence the age that the caller would be screened. But she's certainly at an increased risk, and the younger those family members were at the age they were diagnosed with colon cancer, the greater is the risk for the caller. So in terms of screening, she should get her first colonoscopy at an age 10 years younger than the youngest of those two family members were when they were diagnosed with their cancer.
Okay. And Dr. Rage, here's a question from Anne here in Duluth. How do antibiotics affect the GI system, and do they kill good bacteria?
So the answer is yes. Antibiotics do usually cause diarrhea, and that's through the way of killing some of the normal gut flora that we have in the colon. And not all antibiotics do that, but the vast majority of them do cause some loss, which over time that will get repopulated.
Okay. And Dr. McKee, question here from Joel in Proctor. Is there a defined start to the colon?
Well, there's an anatomical start to the colon, sure. The beginning of the colon is where it joins the small intestine at the ileocecal valve, so that would be the beginning of the colon. And that first part of the colon is called the cecum. And so yes, I mean, there's a beginning and there's an end too. where it connects to the rectum.
Okay. And then Dr. Rage, Jim from Hawthorne asks, peppermint oil, does it have any impact on IBS symptoms?
There are some indication for peppermint oil. I'm not aware of any study that proved that it's helpful, but there are patients who do take peppermint oil and say that they've noticed significant improvement in their symptoms. So given that there isn't side effects that we worry about with peppermint oil, I think it's worth a try.
Okay.
And if you respond and you notice the symptoms are improved, then you definitely continue taking it.
Okay. So I want to thank our panelists, Dr. Daniel McKee, Dr. Ayan Rage, and our medical student phone volunteers, Kate Anderholm, Amy Larson, and Leah Larson. Please join Dr. Adrian Westmoreland next week for a program on diabetes, diagnosis, complications, and treatment, when our panelists will be Dr. David Hutchinson, Dr. Neha Kiblawi, and Dr. Robert Soberg. Thank you for watching. Good night.